Now, as we see here, it is important for us to look at integrated healthcare as a new model of care, but it's also just bringing people together. And there are some core strategies or core guidelines to integrated care that everybody needs to follow, or that a program needs to follow to be considered integrated healthcare. If you can see, there are key elements. These are 5 key elements that are the same no matter which model you choose. Now, for our breakthrough project, we are going to be focusing on PCBH, which is patient-centered behavioral health model. Kara, did I get that wrong? Cool.
Primary care behavioral health.
Primary care.
Thank you. Thank you. Primary care behavioral health. Now, that is what we are going to be focusing on with the breakthrough model. But it is important to know that no matter the model, these 5 principles are the same. And they are that 1, this is a person-centered team care. There is integration. It is more than just 2 people having offices together. They have to learn to work together differently. But this is also population-based care. This means that there is an access to shared records. It means that quality outcomes and measurements are tracked for all patients. It's not just patients who might have a diagnosis of a mental illness, it's literally everybody so that nobody falls through the cracks. It's important for us to be looking at this and understanding that our treatments are measurement based. Treatments are changed until clinical goals are received or achieved. This also has to be evidence-based care. The treatment used, screenings used, all of that has to be based in evidence. And more than anything, the patient has to experience the feeling, the seamless care of being at a one-stop shop. It doesn't matter what kind of care they're going for, they're going to the same place. They have a team that works together for their overall health. That is incredibly important, that the patient notices the difference of the team working together. Okay. Now, as we kind of go on, I do want to talk about the 4-quadrant level model of integration. This is a different way of looking at how risk and complexity can really come together. And it's important for us to look at that in terms of our client and patient population. Now, a lot of times when clients or clinics start to integrate, it's because of potentially a small population of their clinic creating a great deal of energy output. And we are having to create solutions for people with high risk and high complexity. What's important to look at when we're starting to integrate care is how do we look at creating a product or a process for the majority of our clinics or the majority of our patients. So we're going to look at this really quick. Now, for the most part, for breakthrough, we're going to be kind of living in the quadrant 1 area, but it's important for us to talk about all 4 quadrants, and so that we can get an understanding of where the majority of our clients lie. So, quadrant 1, these are clients with low behavioral health risk and complexity and low physical health risk and complexity. This definitely fits into the primary care behavioral healthcare model. And these are clients that are served and well served in a primary care setting. This is where physical healthcare providers and behavioral healthcare providers have screening tools and behavioral health practice guidelines. There are strategies in place to help all clients. Now, there is a behavioral healthcare provider on staff to support any PCP and the patient. It's incredibly important to understand that the patient is a major part of the healthcare team. Now, to help with that, a behavioral health provider can also teach literacy classes for patients, both for behavioral health needs and for physical health needs. So a patient that would really fit well into this quadrant of integration would be somebody who potentially has a diagnosis of moderate depression and fibromyalgia. Both of these things can be treated and controlled in a primary care setting, and they are low risk and low complexity. So this is somebody who would be well served from this. All right, now, as we move to quadrant 2, it's where it starts becoming a little bit more complicated with somebody who potentially has high behavioral health risk and complexity, say bipolar disorder, and low physical health risk and complexity, say high cholesterol. These are things that, again, still can be treated in a primary care setting. And again, this can be used with either model, either primary care behavioral health or collaborative care model. So it's important to understand, though, that those core ideas are the same, that physical healthcare providers have shared screening tools, behavioral healthcare providers have standard screening tools, and they are also working together, okay? They have those processes in place to work together. And again, these are clients who are well suited in a primary care setting and are getting the treatment that they need there. Now in quadrant 3, it is starting to be where things become a little bit more specialized. This would be somebody who has low risk and complexity in a behavioral health setting, such as moderate depression, anxiety, but has incredibly complex physical health risk, such as uncontrolled diabetes. This is really well served in specialty healthcare providers, such as OBGYNs or endocrinologists. This is, again, that more specialized care, but it's also bringing together that behavioral health provider to support the idea of, say, at a pain management clinic, having a mental health or behavioral health provider to help clients understand behavior and understand pain management. Again, the classes are also can be offered, but we're also offering those other community supports. It's about bringing together those practice guidelines, those classes, and those supports together to really support these clients, because we understand a very intense specialized need. Now, quadrant 4, it is where we have the highest level of risk with both behavioral health and physical health, and the highest level of complexity. Again, schizophrenia with, say, metabolic syndrome, Parkinson's, things of these nature, things that take very specialized care on both the end of a behavioral health provider and a physical health provider. So again, this is more of a setting of a behavioral health home and very specific areas. I believe that the Harris Center has a behavioral health home that does focus on very specific and specialized areas. Now, again, as with all the quadrants, there are screening tools, there are pathways, there are behavioral health practice guidelines, and there has to be a behavioral health clinician and the case manager on the support team. So again, all of these have very similar guidelines, but where that starts getting more complicated is as the risk and complexity increases, the level of care, not level of care, but the amount of complexity puts it in different levels of integration. So this is all really important to think about. And often when we start to talk about integration, we begin with the idea that many, if not most of our clients are in quadrant 4, right? The very high risk, very high complexity. And that's kind of what brings us to the idea of integration. But what really is important to keep in mind is so many of our clients can be treated in a primary care setting, even with high risk and complexity. So to that end, I want to share a quick patient story. All right, so what we're going to do here, and this is a little bit of an activity. So what I want you to do is I want you to listen to the details of this story, and then we're going to ask you, which quadrant of integration would you put this client or this patient in? Okay, so I'm going to give you guys some details of the story, and which level of integration would you put this patient in? Okay, so hang on just 1 second. Okay, this patient is a 64-year-old female with with major depressive disorder, co-occurring substance use disorder, which is currently under control. She is also the survivor of a heart transplant due to congestive heart failure. Heart transplant, she does have a care team that she meets with on a quarterly basis and for different lab work and testing, etc. She is currently immune suppressed. She is currently under medication management as well. She is currently seeing a psychiatrist, and she is currently under Medicare. Now, her behavior needs are also being managed where she is. Now, I'm going to go ahead and pull up the next slide, And we're going to show those 4 quadrants of integration again. Now, as we've talked about this again, 64-year-old female, major depressive disorder, co-occurring with substance abuse, which is under control. She has a survivor of a heart transplant with congestive heart failure, and she is currently in the care of a heart transplant team. I want you to go ahead and look at these quadrants, pull up the chats, and if you think she is in 1, 2, 3, or 4, go ahead and put that in the chat, and we will see what your answer is. Okay. Okay, we've got a 3. What else? A 4. Or I'm loving the Roman numerals. Thank you. Okay, all right. We're getting lots of 3s and 4s. Okay, as it turns out, this client, yeah, and if you use the Roman numeral, you won, obviously. But as it turns out, this client is in quadrant 3. She is under the specialized care of a heart transplant team, but she sees a psychiatrist and works and is integrated in a primary care setting other than that. So it is important for us to really look at the complexity of our patients, because a lot of people say, oh, this is quadrant 4 because of the complexity of her health or of her mental health. It's important to keep in mind, though, that her mental health or her behavioral health care needs are being met, are being controlled. It's her physical health complexity that makes her treatment much more complicated. So that's important to keep in mind as we're kind of starting to build this process of integration. Now, what I want you to do is either in your team or individually, take a second and really think about where the majority of your clients or patients lie. Are the majority of your clients in quadrant 1 with low risk, low physical complexity, in quadrant 2, 3, or 4? We'll take just a second and go ahead and type that in the chat. Where do you think the majority of your patients lie? Okay, so we see some 3s. Okay. 1 and 2, absolutely, because it's a primary care setting. Okay, where else? 1 to 3, it can kind of run the gambit, absolutely. Okay, and that's really important for us to look at. Is a lot of time when we get started, we start thinking about those really high risk, high complexity clients, but we have to build a system for the majority. We have to make sure our system works for the majority of our patients. And so this can be 2.5, absolutely. And that's important for us to look at and really be careful as to how we determine that level of complexity and how we build systems for our clients. Now I'm going to go ahead and hand it off to Sujina, who's going to talk a little bit more about the different models and the differences and similarities between those models.
Okay, thank you, Lauren. Can you hear me? Okay. All right, so we're now going to discuss the 2 basic models when incorporating behavioral health into primary care. Primary care, when adding behavioral health, has 2 basic models, and they are the primary care behavioral health model, also known as the PCBH model, and collaborative care model. Before we discuss these models briefly, it is important for us to remember, like Lauren mentioned before, that no matter the model, it is important that the care is person-centered and collaborative among your team members. So it's not just co-located. Make sure it's measurement-based treatment and evidence-based treatment, and provide an overall one-stop shop patient experience. Okay, so first we're going to discuss the PCBH model. The PCBH model focuses on team-based care and population-based approach. So here you're looking at the entire population of your clients and working together as a physical health provider and a behavioral health provider to improve the health of your entire patient population. In this model, the behavioral health provider are often called behavioral health consultants, and they're counted as part of the entire team and serve as a generalist and an educator. So now, what is a generalist and an educator? So the PCP or family physician or pediatrician is really considered a generalist, right? Because they're looking at countless numbers of conditions when looking at and serving the patient population. The behavioral health consultant is looked at as that kind of generalist when it comes to behavioral health, mental health, and addiction. They're looked at as someone that has the ability to be a generalist and an educator, because they're not only educating the entire primary care team, but also educating the patients and their family members. And they're able to identify and address myriads of conditions. In this setting, the behavioral health clinician and the behavioral health consultant should be sitting in the same spot as your PCP, your MAs, and your nurses, and counted as your core participants, so they're accessible for an on-demand warm handoff. For example, if a physician is seeing a patient that has a condition that could be improved through the behavioral health consultant, that behavioral health provider should be available right there and there to do the warm handoff. They're then, so that they're easily able to take over and do the quick intervention immediately. So in this model, our behavioral health consultant, they do brief intervention for functional improvements. They're using these best practice model that the behavioral health providers typically use in 45-minute session. But here it's brief, as they're only around 16 to 30 minutes, yet they're using the CBT, coping skills, and all other standard skills that are needed to do the regular therapy session, but here in a medical session, and they're brief. Generally, not only it is brief intervention in that moment, it is also not a long-term care. It can be a pair that prepares the patient to take ownership in their health and their healthcare, including their mental health and their physical health, and can usually be addressed in 4 to 5 brief intervention or over a short period of time. So that's the PCBH model. Next, we're going to discuss the collaborative care model. So the collaborative care model might be more useful for a patient with bit more complex cases who may need some psychiatric intervention. In this model, the primary person who treats the patient is actually considered a primary care provider. This model, again, focuses on the same key elements, such as person-centered, collaborative care, population-based, measurement-based treatment, and is served as a one-stop shop for the patient. This patient, in this model, the patient is seen by the primary care provider. There's a behavioral health manager on site as well, who can help the primary care provider if there's a behavioral health concern in a patient. And there's a need for a warm handoff, or if there's a longer term therapy needed by the behavioral health provider, or any other support that is needed from them. And most importantly, it is also focused on a very specific population within the clinic. So the providers will work with the patients that are already diagnosed with, for example, diabetes or depression or COPD and anxiety. You would then create a registry where you track the health outcomes of this population and have weekly consultation between the behavioral health provider, primary care provider, the psychiatrist. So then the psychiatrist can give feedback and make a recommendation to the PCP on the medication management, or make a recommendation to the behavioral health manager on specific type of therapy to help the patient. And then based off of these recommendations, the primary care provider or behavioral health consultant can go back to the patient and talk about these recommendations, make some choices with the patients to on the next steps, the action planning, and the care planning with the patient. Okay. So those are the two very big models. In this diagram, in this Venn diagram, you can see the similarities and the differences between the two models. While the collaborative model generally focuses on a specific diagnosis, they have a patient registry, psychiatric consultation, and there's a planned behavioral health follow-up that might include specific patient visits with just the behavioral health provider, that might include longer term therapy. But when it comes to PCBH model, it's not necessarily focused on specific diagnosis. There's a more real-time availability for a warm handoff within the primary care setting. But when compared to collaborative care model, there is a possibility of warm handoff, but that may not always be possible if the behavioral health care manager is doing long-term therapy with the patient, whereas the PCBH model focuses on brief intervention and short-term care. And lastly, in the PCBH model actually is the only model currently in the state of Texas that is an integrated model, which is billable and reimbursable for Medicaid. So it's cost-effective, cost-saving, team-based care. There's a behavioral provider on staff, and it's evidence-based. Does anyone have any questions?
I just want to make one comment about the collaborative care model. There was legislation at this past session to mandate that those codes get turned on, and that legislation passed. We are currently working on finding the details and the wording of that, the timing, and working with our MCOs to figure out how they want to begin to roll this out. So as that information becomes available, we will definitely share that information with you all. They're not on yet. I think the soonest they could be turned on is September, but it's a whole different way of doing integrated care than the PCBH model. There are some hybrid models that combine these two, and we are going to be actively researching how to share information and figure out what their practice is if they're interested in doing the hybrid model.
Right, so similar to the activity before, what I want you to do now is open up your chat box and type in your answer to the following question. Do not hit enter until I ask you to do so. Here is your first question. Finish this sentence. An uncertainty I need answered is. Okay, you can go ahead and enter. Okay, Kara, can you take a look at the chat because I'm not able to see it?
Sure, there's no one's typed anything into the chat. Oh, how is this billable for FQHCs on a set rate with Medicaid? Good question. How to maximize revenue for PCBH? Very good question. So yes, so it is the HBAI codes for the patient primary care behavioral health model are billable and reimbursable with those RAP payments as a second service on the same day. You are able to use those codes. Those codes, if you've registered, if you've not, there's still time in July. We have a very specific training on how to pay for integrated care with fee-for-service codes. And we will talk about the exact codes to use, how to use them, the documentation that's needed to use those codes. Valerie, is this Dr. Smith? Dr. Smith, great question. It's really something that As a team and scheduling for brief interventions is definitely a new way to figure out how to schedule. Sometimes we look at our schedule and you have to have your scheduler involved and have a 30-minute visit rather than a standard 15-minute visit with the PCP, so that there's time for the behavioral health provider to come in. We will definitely, as a part of the Breakthrough Series Learning Collaborative, have opportunities to discuss scheduling, the challenges around scheduling and implementing scheduling for brief interventions. We have some behavioral health providers that will be able to address that through the Breakthrough Series. It's a very common challenge. Dr. Parks, your question is how to evolve in a tree?
Often we have like these models and they look good on paper. My question is, how do we evolve like a model that is truly integrated, where everyone is vested in the outcome? Because so often there's like a lot of great ideals on paper, but they don't translate to real life models. So that's my question.
That's a great question. And Dr. Parks, what organization are you with?
UT Health.
Oh,
Heights Clinic.
I'm sorry, UT Health, and then what?
Heights Clinic.
Heights Clinic. Wonderful. Welcome. Yeah, it is a huge challenge. And what we will be working on within the Breakthrough Series Collaborative are the 3 most important points to begin to transform your system. And one is to make sure that you have leadership endorsement and leadership involvement. So we'll be focusing on the changes that the leadership needs to undergo in order to support a transition to this model. And then we will talk about clinic practice and workflow. So those things clinically and your workflow, and like Dr. Smith said, your scheduling. And then talk about financing and payment. How do you financially sustain? And so we are going to give you all very specific changes and steps to make along those changes in order to transition your system, as well as measurements. How do you know that those changes are actually improving and actually providing integrated behavioral health? So we'll look at some measures within that. Dr. Parks, it's a slow process, right? Like, this is something that takes time and patience and diligence, and it's challenging along the way. So what we want to do is provide as much support as possible as all of you transition step by step through really a model of improvement and PDSAs to begin to change the way you operate and become more in line with integrated behavioral health. That's a good question, but there are systems out there that do it, and our expert consultants that will be joining us as a part of the Breakthrough Series Collaborative will be from clinics and practices all throughout the nation that operate at high levels of integration within these models. I'm going to do the next one, clinic, Sujina.
Yeah, I just wanted to ask another question for everyone to type in their answer to. That is what I hope could happen in my clinic regarding integrated care is. go ahead and type in your answer and send and hit enter.
Adriana, to treat your patients in a true integrated fashion and improve health outcomes. Very good. So increased communication in the practice team. Yay, that is probably one of the most essential things in integrated care, is that improving communication among your practice team. Having people invested and our providers invested, which is very important. So as you put these down, these are really good things to take back to your teams. We will get a copy of this chat. Dr. Parks, more holistic care for our patients, improved patient outcomes. Valerie, Dr. Smith, I love that. So when we go into our first learning session in September, we will ask, what is your goal? What is your goal for your clinic? As the goal for the Breakthrough Series Collaborative is that our clinics will increase their level of integration by, that they will increase their level of integration in 1 year. We will see that there are measurable improvements. And so what is your goal within that? And all of these goals fit, right? Workflows and care teams can be optimized for full integration. Dr. Young, great goal. So these are great goals for you to start to put on paper and say, how do we get to that goal? And when we provide your changes, your change package for you, how do you line up those changes, which we will address all of these that I've seen so far in our change package. How will you use those changes and the measurements to make sure you get to that goal? So what we will do after this is make sure we get a copy of the chat. We will send your team that is here today the goals that you have put in here as a talking point and something to think about as we progress through this process with you all.
Okay, so here are our next steps. In 2 weeks, we're hosting our Understanding Integrated Care Part 2 training, where we'll discuss more about these two models and the level of integration, as there are very specific ways and aspects of a clinic that can help improve integration and to assess where you are now and where you want to be. We'll also be hosting how to pay for integrated care in a fee-for-service environment training, which will discuss the common codes used in the integrated care, which align with the common model. There are PCBH codes, collaborative model codes, and we'll discuss various other models and the coinciding billing CPT codes that go along with it. And then I hope by now you guys have registered for our Project Echo 102 series. We hosted our informational session last Monday. If you haven't done so yet, and if you need help with that, please let me know. I'll be more than happy to guide you through that process. But our first session will be held on Monday, the 21st at 11 a.m. And Dr. Ebony Winford will be our first presenter. So we're very excited to get started with this series. Make sure you have registered for that. After Project Echo, you guys also had an option to sign up for our orientation. You have two options. You only have to select one. And once you register and go through that orientation, we'll finally start our Breakthrough Series Collaborative Learning Session #1 in September. Okay, anyone has any questions? Please let us know. You can unmute yourself or type in the chat box your question. We'll be more than happy to clarify anything for you.
So we don't have any questions coming in right now, Sujina. But
So here are the key takeaways. There are key elements no matter the model, and they are person-centered team care and they're collaborative, population-based care, measurement-based treatment, evidence-based care, and they're focused on patient experience. Quadrants, all 4 quadrants are a way to look at risk and complexity of behavioral health needs and physical health needs. All 4 quadrants include screening tools for both behavioral health providers and physical health providers. Quadrant 1 and Quadrant 2 are more focused in primary care setting, where Quadrant 3 is focused on specialist care, and Quadrant 4 is focused on behavioral health homes. And lastly, the 2 best practice model, the PCBH model, focuses on the team-based care and population-based approach. So you're looking at the entire population of your clients, working together as a primary health provider and a behavioral health provider to improve the health of your entire patient population. The behavioral health provider in this model are considered part of your team and are more accessible for an on-demand warm handoffs, and they're focused on brief intervention. The collaborative care model is used for a bit more complex patient who may need psychiatric intervention. So in this model, the primary care person who treats the patient is considered a primary care provider. It has patient registry and also offer psychiatric consultation. There's a possibility of warm handoff, but it may be depending if the behavioral health care manager is already doing the longer term therapy with the patient. So it's focused on longer term care compared to PCBH model, which focuses on short-term care. And that's all we have. Thank you all so much for joining us today. It was a pleasure having you here with us. I hope you found this training informational for you. If you have any questions, you have my email address, and we look forward to seeing you all next week on Monday for our Project Echo, and then soon after for the other 2 trainings we've lined up for you, and then again for the orientation and the learning session of Breakthrough Series. Thank you all so much. Have a great rest of your week. Bye, all.